وأعزائي سوف نسلط الآن الضوء على أحد الأمراض الصاعدة المهمة والمنتشرة في العالم وفي الكويت، ألا وهو مرض هشاشة العظام. ونستمع وياكم الآن لمحاضرة بعنوان هشاشة العظام يلقيها الدكتور ثامر العيسى، وهو مسجل الأول في أمراض السكر والغدد الصماء في مستشفى مبارك كلية.
Good afternoon, everybody. Thank you for inviting me, for the organizers. Actually, further even, thank you for recognizing this disorder to be one of the things that to be on your topic for discussion, because it's such an important disorder right now. And, a lot of people get diagnosed, a lot of people get misdiagnosed about it. So thank you for shedding the light. Thank you for inviting me, and we can start the slideshow. So whenever we talk about a disorder, it's important definitely to define it, to know what it is, and then we can deal with it. So if you look at the definition of osteoporosis, it's a systemic skeletal disorder. And a lot of people think the opposite, since it affects a certain part of the body, a certain bone. And if that bone is osteoporotic, then everything else is fine. And that's not true. So it's a skeletal disorder. So if you have one part of your body that has osteoporosis, then you have the disorder. So then you have the disease. So it's a systemic skeletal disease characterized by low bone mass, and we mean by that at bone density, and microarchitectural deterioration of the bone tissue. So it's not tight, it's not strong, it's not dense anymore. With a consequent increase in the bone fragility and increase in the fracture risk. And that's what we try to prevent. And that's what the problem is. We give all these medications, we give all these lectures and talk about preventing it to prevent the fractures. And it's in one of the main causes of fractures, especially in the elderly, above the age of 50, is definitely osteoporosis. So to understand even more, we need to know how the bone works. What's the metabolism? How is the life cycle of bone? Bone goes through a specific remodeling phase, which combines of several steps. It's a living organ, just like anybody else. I mean, any other organ in the body. There's a phase where the bone sheds off, and then there's a phase where the bone builds up again. So the first part of this cycle is the part of when it gets activated. Of course, if you remember from your histology, there's two sets of important cells in the bone. There's the osteoclasts, which break down the bone, and there's the osteoblasts, which build the bone. So the cycle starts when the osteoclasts get activated, and they come into a normal bone and they start to break it down completely. When they reach that point, new cells come along, which are the precursors of the osteoblast. The osteoblasts start lining down on the bone that has been eaten and destructed by the osteoclast. Start to lay down its matrix. That matrix gets hardened and mineralized by the action of calcium and vitamin D, which we will mention later. And those cells, the osteoblast cells, either will form into the osteocyte, which is part of the matrix of the bone, or be the lining of the bone itself, where it will be activated again to call on the osteoclast to start a new cycle. So the change in bone mass definitely goes with age. So as you grow older, you accumulate more density in your bone, and that's because of our lifestyle, of how we grow, how we eat, how we do our things. We accumulate more density. Our bone gets thicker. But once we reach a certain point of age, that density declines, and the bone mass itself, the thickness of the bone, also decreases. And that happens definitely around the age, especially in women, and think right here, which is the time of menopause. And that happens because they lose the estrogen effect. And bones love estrogen, and they live by the action of estrogen. It maintains their density, it maintains their thickness, it preserves its function. So without it, you can definitely monitor and see the density of the bone gets down. Also in men it happens, and the men, not because they lose any kind of a sex hormone, they don't go into menopause, but what happens is that their lifestyle gets different when they get older. right? So they get deficiency in certain things, they get medical illnesses and a lot of other things, and that puts a lot of burden on the bone. So they lose bone density. But they do that much later than ladies, much later than women. And you can see that they start declining more than that. But also interesting that their density is even thicker when they start their process of growing up. So men have thicker bones, and they lose it much later than women. So that's the main difference between men and women. Not only that, but if you look at the fracture incidence and the fracture ratio in men and women, women start to fracture their bones around the age between 45 and 55. So the boxes are women and the triangles are men. So around between the age of 45 to 54, it starts which is the time of menopause, that's when women start to break down their bones more and they have fractures. Men actually last longer when they have a stable fracture risk. But once they reach the age of 70 and 75, the rate of fractures increases. And that's mainly because of the lifestyle, and at that time they start losing their density. A recent study was still in press, which had about 2,300 females, I believe it was done here in Mubarack Hospital, where they want to look at the prevalence of osteoporosis and the prevalence of low bone mass, here, which we call also osteopenia. They saw that 19% of the population that they looked at, which were supposed to be healthy, between the ages of 40 to above 70, they looked at and they saw that 19% of those ladies have osteoporosis. So it gives an idea of how prevalent osteoporosis we have here in Kuwait. There's some studies which even done in a smaller scale which had a slightly higher rate than this. So prevalence of osteoporosis, 19%. The prevalence of osteopenia, or the low bone mass, is about 45%. So almost half of those ladies had the low density that what they should have. And you can see here that as we grow older, the prevalence of osteoporosis also increases. So the ladies there, the women above the age of 70, the prevalence of osteoporosis is much higher. It's about 40%. Osteoporosis also is a disabling disorder. And we can understand that by looking at what we call the disability-adjusted life year, which is, it calculates how many years are lost from a person's life due to illness or disease or a certain condition. And this is one of the studies that was done in Europe, I believe in 2006, where they studied a group of population and they found that osteoporosis is a significant disorder that can cause disability in life. And it's actually the fifth after the cause of ischemic heart disease, COPD, osteoarthritis, Alzheimer's disease, and cirrhosis. So it's a very common disease to cause a lot of disability to people. How much it costs osteoporosis for a government or any kind of organization or community? Well, we don't have good studies here in the Kuwait to decide that. But if we compare it worldwide, we know that if someone fractures a hip in the USA, the cost of hospital stay and everything is about 12,000 KD. So that's significant. In Iran, they did a study. We looked at how much it cost them to get a hip fracture for all their population, and they find it's cost between 250 million to about 4,500,000 KD. So it consumes a lot of budget from the ministry. It definitely consumes a lot of budget from the out of pocket if you're actually paying from your own money. Osteoporosis in men, it has a tiny little bit different way and description than women, because it's not even that common to see. But the problem is that with mortality, when men get osteoporosis and they start fracturing their bones. So from what we know is that, from what we know is that 30% of all hip fractures, they occur in men. So a third of them. And also the vertebral fractures, 20% of what we call the clinical vertebral fractures occurs in men. So what do we mean by clinical? Clinical means a fracture that a patient feels and presents to an emergency or a doctor and starts complaining from whatever the pain or whatever the fracture has caused. But also we have the silent vertebral fractures that are very common. And men actually have that much more than women. until the age of 65, when after that they start to equalize a little bit. So what we know by this, so that means that men do fracture their vertebrae, but in a way that we cannot actually know. So the prevalence of osteoporosis and vertebral fracture in this population might be really underestimated. And that's what I wanted to show you. And important also is that the mortality in male hip fracture patient is 2 to 4-fold higher than in women. So not only that the men fracture much later than women, but if they do fracture, the mortality rate is much higher than women. And that's what you need to understand. And also slightly higher if they fracture their vertebrae. Causes of osteoporosis, there's a lot of causes. You can open any textbook on any online source and just start reading the causes. I'm not going to really run through them all, but just want to point out the most important ones, which part of our discussion at the end is the lifestyle factors. And the lifestyle factors include vitamin D deficiency, low calcium intake, and we showed you how that's important for mineralization of your bones. Alcohol consumption is also a key factor in health of your bones, and smoking. Those are the lifestyle that we actually can do and change. Other causes are basically disorders that we can successfully treat and successfully not treat, and they can cause also osteoporosis. So who's at risk? I mean, there's a big table previously with all the causes, but who's at risk of osteoporosis? The main ones are if you have a small frame or an elderly woman. So she's at high risk of having osteoporosis. All postmenopausal women, that's understandable, but especially who develop menopause at early age, like before their time. Smokers, whether they're men or women, whoever consuming very low amounts of calcium and vitamin D in their diet, and I'll tell you to do the calculations to know how much you're consuming. Alcohol consumption, maybe we don't have that much here. Inactive lifestyle, including immobilization also, so if you have someone who's bedbound or bedridden, that's also a risk factor for developing osteoporosis. Steroids is a big key, a big thing that causes osteoporosis, and we know that. Anticonvulsant therapy also. Whoever has rheumatoid arthritis, not because of the therapy of rheumatoid arthritis, but just having the disease itself, the inflammatory condition that happens at the same time. That's the risk and triggers the osteoporosis cascade. And family history of hip fracture or osteoporosis. That's also a very important risk factor. So those are people who are at risk. Symptoms, as we mentioned, osteoporosis is a silent disorder. Doesn't give any symptoms, no warnings, except when you actually break a bone, unfortunately. When that happens, when you break a vertebrae, well, the typical symptoms is an atypical sharp lower pain in the back. That probably you think this is related to arthritis or something, but a lot of times it happens because of a fracture of the vertebrae. When a fracture happens in the vertebrae, the fracture is compressed. So what happens if you have even more than one vertebrae fracture, you can actually lose height. So one of the sensitive things when you ask your patient is that, are you losing height? Were you taller before and now you're shorter? Did you lose 2 or 3 or 4 centimeters? So that's what keeps you thinking that they probably have some things in the vertebrae. When more fractures happen in the vertebrae, they start their spine start curving forward, what we call kyphosis. And if that happens a lot in several of those vertebrae, they've developed this hump in the back, what we call the Doger's hump. And that's a sign of a poor vertebrae that has been probably osteoporotic and been fracturing all over. And the hip and the wrist is also silent unless you start actually breaking and having fracture in it. And what we mean about fragility fracture. So there's a regular fracture, there's a fragility fracture. So fragility fracture means if you break a bone without really a good reason. So if you have someone who was in a car accident or fall from height or broke a bone, you can understand that. But if you have someone who slipped and fell and broke his arm or hip, that's not normal. And that's what we call fragility fracture. And those locations are the wrist, the hip, and the vertebrae. So those locations, if you have a fracture that is unexplainable and no good reason for it, then that's a fragility fracture. So how we diagnose osteoporosis? The best modality we have is the dual X-ray absorptiometry, or what we call the DEXA scan. It's just a typical X-ray machine, but it has a different kind of setting. It's a table, patient sits on the table, lays down on the table, with a camera that beams lights, and you have a receiver here. All this, the patient goes to the screen, and you have a tech who reads this screen and starts to put marks at the locations where we measure the head, measure the density. And we use this machine to measure density in 3 major locations: the spine, the proximal femur, and the forearm. And we use them to either diagnose osteoporosis. We use them sometimes to predict the risk of fracture, and there's a special modality calculation that we use. And also we can use it to monitor therapy to see how they're progressing. Are they losing more bone, or they're okay? So the report comes up something like that. So you have a picture, you have all these marks, and you have a picture of the hip, and then also the marks on it. So typically when we do a DEXA screening, we do a spine and a hip. Sometimes we add a wrist for a certain indication, but this is typically what's been done. So, and all this table, all these numbers, what it means here that is the bone mineral density, BMD. So BMD is bone mineral density. They give you that result of the patient. But that's not the one that we actually diagnose osteoporosis with. The one that we diagnose osteoporosis with is the T-score. So how does this T-score came? So T-score means how much standard deviation you are far away from someone who has a normal bone density, a young, a fit person. So, and then the amount of standard deviation that you are far from that normal person is the T-score. So the WHO made up this diagnostic criterion set. Whoever is a T-score of -1 and greater means that you are within 1 standard deviation of what is normal, then you're okay. But if you're more than that, up to 2.5, then you have a low bone mass, or we call osteopenia. If you're even farther away from your mean, a T-score of -2.5, then you definitely have osteoporosis. And if you do have that with a fracture, we call that a severe degree of osteoporosis. So who's to test? Do we test everybody for osteoporosis? No. There's certain recommendations for that. So we said all women aged 65 and older should get a DEXA scan. At least once in their lifetime at least. Postmenopausal women who are under the age of 65 who have risk factors for fractures or risk factor for osteoporosis, and we've mentioned that, and who's at risk at all the causes. Men who are 70 years old or older, and men who are less than 70 years old who has a clinical risk factors for fractures or osteoporosis. Any adult, whatever, regardless of the age, who had a fragility fracture, and we talked about the fragility fracture, what does it mean, right? And anyone who's on therapy and needs to be monitored, we do them a DEXA scan. So how to prevent osteoporosis? Most important thing, as I mentioned, what we wanted to talk about is the lifestyle. Otherwise, all diseases, we can treat them, we cannot treat them, but the things that we can prevent really is the lifestyle changes. So calcium, vitamin D, regular exercise, stop smoking. Those are the most important things. We can add alcohol into the list, but it's not probably a big concern right here. But we'll talk about those 4 or 5. So 99% of calcium in the body is stored in the bone and in the teeth. So it's a primary component of your bone health and your bone status. So how do we know that we're consuming a normal amount or good amount of calcium? Well, we need to look at what we eat, basically. Cooked food at home may be a little bit hard to understand how much calcium it has. But if you're actually buying products from the shelves in the supermarket, then you probably can understand and know how much consumption of calcium you do. And you do that by reading the food labels. A lot of our products, unfortunately, they don't have a good description on the products of how much calcium they have, but some of them do. And there's 2 ways of describing how much calcium in a product. Either they name how much milligrams of calcium there is, or they can label it as a percentage of the daily value. And DV stands for the daily value. So here, this product here, if you look down at calcium, it tells you it's 20%. So it's 20% of the daily value. But what is the daily value? How much we need? Well, the manufacturing companies, they made 1,000 milligrams of calcium is a good requirement, or an average requirement for a normal person. So when they say 20%, so 20% out of 1,000 milligrams, that's 200 milligrams. So you know, this serving of this product will give you 200 milligrams of calcium. So that's an easy way to how to calculate it. Also, the typical diet that we eat on a regular basis that doesn't come fortified or come rich in calcium. The total amount of all this diet that we consume is probably has about 250 milligrams a day. So where are the sources of calcium? Where do they come from? So mainly dairy products. They also available in lactose-free form for who is lactose intolerant. So milk, yogurt, and cheese. Those are the standard ones that we use it always as a reference. Green vegetables are very important. Calcium fortified food that added into them, like juices, breakfast foods, soy milk, cereal, bread, and bottled water. All these minerals, all these things could be added to calcium too. And so how much do we need a day? So it's really that we need a day about 1,000 to 1,200 milligrams of calcium. And it should be enough. And if we're taking supplements, as a calcium supplements, calcium is absorbed best when the amount of calcium given in a single dose is about 500 to 600 milligrams. If you give 1,000 milligrams into the stomach, probably the stomach would not really absorb everything at the same time. So give it about 500 to 600 in one dose. For calcium supplement itself, the calcium carbonate is the most effective form. It's most cheaper and the best absorbed and the best bioavailable. And the one that the government here prescribes in the pharmacies is actually calcium carbonate. It's best taken when it's taken after meals. Also, we have calcium citrate. If you're taking calcium citrate, it should be taken between meals. And calcium supplements are not a substitute for medical therapy. So they're not medical therapy for osteoporosis, but part of lifestyle changes that you need to do. So how do we calculate? So I told you milk, yogurt, cheese are our reference. So 8 ounces of milk, about 250 ml, will give you about 300 milligrams of calcium. Okay. Also, 6 ounces of yogurt, about 180, will give you also another 300. 1 inch or 16 centimeter square of cheese, or you can weigh it like 1 ounce or about 30 ml of cheese, will give about 200. All the rest of fortified food and juices, we don't know how much they have because they're not really labeled. So we assume they're average between 80 to 1,000, so there's a big range. And as we mentioned, the rest of the food that we consume is about 250. So for someone who wants to consume like a cereal, bowl of cereal in the morning with a cup of milk, and then later in the day maybe another cup of milk. So if he uses two 2 ounces of milk, then that's about 300, so that's 600. Let's say a bowl of cereal contains about 500 milligrams of calcium. He likes to eat a yogurt a day, so that's about 300, and doesn't like much cheese. So the total is 1,650. So that person actually doesn't need any requirements, doesn't need any supplements, that's what I mean. So his diet is very sufficient for calcium. Okay, vitamin D. The vitamin D, of course, we know comes from the skin. The manufacturing the skin because when we exposed to sunlight, it comes also from dairy products and fortified foods, and also from supplements. All the vitamin D goes into the liver, where it's manufactured into the 25-hydroxide vitamin D, and then that molecule also gets activated in the kidney mainly to the active form, which is 125-hydroxide vitamin D. The one that we measure for clinical diagnosis and therapy and monitoring is the 25-hydroxide vitamin D. What's the action of vitamin D? It absorbs, didn't come on, right? But it should absorb calcium and magnesium and phosphorus from the GI tract. In the kidney, it should absorb calcium also. In bone, it optimizes the osteomineralization, bone density. And in the parathyroid, it suppresses the PTH because we don't want the PTH to be high. Hyperparathyroidism is a risk factor for osteoporosis. Sources of vitamin D, like salmon, tuna, sardines, egg, liver, some fortified food, but it's very, very hard to get all our vitamin D requirements just by diet. It's going to be really hard. So most likely will depend on supplements. So how to read the food label for vitamin D is about the same thing. So they'll tell you a daily value and they will give you a percentage of that daily value. And you can calculate how much. But the problem is that the manufacturers, when they produce their products, the daily value that they think is enough for you is actually much less than we think is good for you. So those companies say 400 a day of vitamin D is good for you. So they will give you a 20%. So 1 cup of milk, 8 ounces is 25% of your daily value. And your daily value is 400. That is about, so 1 cup of milk gives you about 100. But 400 is minimum. We need more. So how much we need? So a normal level of in the serum, in the blood, for vitamin D is above 75 nanomole. That's about 30 micromole per liter. So, and how much we need to maintain a normal vitamin D? Well, adults will need about 1,500 to 2,000 a day of vitamin D. And you can imagine that's going to be really hard getting it from your diet, right? Because 1 cup of milk could be just only 100. So we most likely will develop some supplements. Insufficiency is when we have a level of 50 to 75, and to correct the sufficiency, we need to give a big dose of vitamin D to build up what we have. So we give a 50,000 units almost every week for 8 weeks, and then we keep them on a maintenance dose. Once deficiency of vitamin D is when the level is less than 50. We give them the same course of replacement, which is 50,000 units, but most likely they will require another course because of their severe deficiency. But we keep them on the maintenance dose, which is recommended for adults, which is 1,500 to 1,000 a day. Who to test for vitamin D? Everybody? Well, maybe not. So we concentrate our efforts on people who are less exposed to sun or mostly covered up. Also, nursing home patients who are bedbound, bedridden, don't leave. And people who have certain medical conditions like inflammatory bowel disease or celiac disease. Patients who are on medications that lower or interferes with vitamin D absorption. Very dark skinned people, they cannot make vitamin D from the skin very well. And obese people, so those are people at rest. A few things more about the exercise, which is 2 slides more. I'm just going to tell you about exercise. Well, first one is the weight-bearing exercises. That's what you need to maintain your bone health. You have a high impact and low impact, depends on how much you tolerate, which are like dancing and jumping. Muscle strengthening exercises, which are resistant exercises, which are important to maintain the thickness of your bones, and cut smoking. Last slide here is the therapy for osteoporosis, and we don't want to talk about that a lot, but there are many drugs are there to treat them. They're broken down into several groups like bisphosphonate, which are anti-absorptive therapy. There's an anabolic medication there for monotherapy we can use, and all of them will reduce the fracture risk and the degree of fracture. So thank you so much for listening, and ready for any questions if you have.
Doctor, yes. Doctor, studies now say that if calcium is given itself, I mean, it must be given along with the vitamin D. Otherwise, if it's given alone, if calcium is given alone, it's going to be a risk factor for osteoporosis. So if a person is taking calcium excessively and is not taking vitamin D along with it, he's going to develop osteoporosis. So,
well, the one that was a controversial thing we talked about last year was a study that came out said calcium supplements without vitamin D will increases the calcification of your vessels and puts you at risk for heart disease and ischemia. Well, it's hard to judge from retrospective study. That's number one. Second thing, those patients were not osteoporotic patients, so they were normal people without any condition. Third thing, they were not given a supplement with vitamin D, so they were given only calcium by itself. In regards for bones, calcium could be effective for as a supportive therapy for osteoporosis, but you definitely need the vitamin D to place the calcium and mineralize it and fix it directly to the bone. If you have a deficiency or a sufficiency of vitamin D, giving calcium by itself would not really help, because I just showed that vitamin D is very important for the absorption of calcium from the gut. So calcium by itself will not be beneficial a lot, and you need vitamin D definitely with it.
Yeah, but Doctor, is it really that excessive intake of calcium is going to be a risk factor for osteoporosis?
Never heard of it.
If it's not taken along with vitamin D.
Never heard of that before, and I don't think so. It doesn't go with the pathophysiology of osteoporosis. Yeah. But there's a study which showed that it increases the calcification of some blood vessels. Yes.
Hannah Al-Qadi, surgeon from Oman. What is your normal values? Because we found out that we're overdiagnosing osteoporosis in Oman. Because we were using the normal values of the Caucasians. And you know the Asians have different normal values, the African Americans, they have different normal values. And the Caucasians have different normal values which are high compared to our area. So how do you adjust for this, or do you use the Caucasian values?
Well, you're absolutely right. The problem is when you're doing a bone density and you're comparing a bone density of the patient, you need a good comparison group to compare it with. Someone who's in a similar category, similar genes, similar environment, similar country. Unfortunately, that's part of what the manufacturers of the bone density bring and use. Majority of data that we have so far are data from Caucasian white ladies, not even men. So sometimes we compare men's density to women's density. It's a tricky subject, and we don't have good studies to use them as data. There's certain areas actually in the Arab Gulf area. There's in Lebanon and Jordan. There are some studies which they used where they came up with some normative data that they can compare their patients to, and they come up with their own T-scores and risk for fractures. We don't have them here. I've never seen anything in the Gulf yet. But there are some countries in the Middle East that they use. But it's something that the manufacturers of those machines have to understand and use rather than the physicians themselves.
So it's a good area to research.
Exactly, yeah. And it doesn't really consume much effort. It just needs budget to do it, because what you're doing is you're bringing healthy subjects, and you're doing bone density to know what's their normal. So you just need a machine, you just need someone who is actually willing to do it, and so that's why it's not really that much of enthusiastic for someone who's looking for a disorder. Nobody's going to be happy doing scans for someone who's healthy. So yeah, it could be doable, but you need the good settings to do it. Yes.
Assalamu alaikum. My name is Arfan. To what extent do you implement the heart therapy and preventing future fractures if the patient is postmenopausal? And there is a couple of studies that says that the implementation of heart therapy usually for as long as 2 years, just to get sure for the complication of the heart therapy. What is the extent of implementing the heart therapy in a patient who's postmenopausal? At the same time, does it prevent future fractures or not?
Thank you for the question. I think it's very important. It's going to open a lot of discussion about it, but definitely, hormone replacement therapy is a big on the endocrine market, let's say. A lot of endocrinologists now recommend routine use of hormone replacement therapy for someone who is postmenopausal, without even having any additional risk for osteoporosis, let's say. Because studies have shown that hormone replacement therapy not only lowers the risk of, which it actually does, lower the risk of osteoporosis and fracture, but it also lowers the risk of ischemic heart disease. And so in a lot of clinical settings, hormone replacement therapy is a standard as a part of recommendation. Estrogen is the effective part of the hormone replacement therapy on bones. It definitely lowers the risk of fracture. It maintains the density of bone, and women who are on hormone replacement therapy tend to lose much less density compared to someone who's not on hormone replacement therapy. So it's protective. Yes, and a lot of people now recommend it as a routine use. Fortunately, it doesn't have a big description on how much effective it is. It has a lot of bad publicity. So I think the role of physicians is to try to see who actually can fit into that group and be prescribed this kind of therapy. Thank you, everybody.